Depression is a mental illness that has been widely misunderstood in the past, and one has to look no further than the previous century to learn of the many appalling methods of treatments patients were infamously subjected to. Amongst these was shock therapy, which was widely used in the 1940s, operating behind the hypothesis that the brains of the mentally ill were in an unbalanced state. Patients were subjected to the first iterations of shock therapy in the form of insulin therapy, which, invented by Manfred Sackel in 1933, attempted to restore homeostasis through inducing comas and seizures. Through its popularization by the London Asylum, dramatic advances continued to be made for shock therapy in the direction towards its most infamous iteration, ECT, which eventually established itself as the most popular form of shock treatment in various other institutions worldwide by 1944, when Italian doctor Saletti and Bini successfully performed it on a human subject in April of 1938. However, success was very limited, and any efficacy that could be attributed to it was almost certainly outweighed by the devastating side effects that convulsions and seizures produced, such as muscle damage and broken bones, all of which were amplified in severity when we consider that no anesthetics were available to patients. With no access to alternatives, alcohol was widely used as a sedative, alongside restraints for more violent and irritable patients. This, of course, served as an additional insult to injury, as patients also had to endure the effects of alcoholism that they developed, which doctors had limited knowledge of at the time. Credit can be attributed to the minority of doctors, such as Dr. R. Maurice Buck, who observed that the use of alcohol is increasing mortality and actually worsening the conditions of patients rather than providing relief, which raised awareness of the underlying problems of treatments and shifted the larger view of the public of the morality behind them, which is what ultimately catalyzed the introduction of legislation in the mid-20th century, which recognized alcoholism as a disease. Inspecting the psychogenic approaches towards treating depression in the first half of the previous century, psychoanalysis bestrode any alternatives. The work of psychoanalysts in the 20th century can be viewed to be commendable, as it was the first instance where scientific principles became the basis of operation for psychogenic treatment, which replaced many previously unscientific concepts such as dualism, which operated largely on a theoretical and philosophical basis. Prevalent psychoanalysts, such as Freud, introduced the concept of melancholia, resulting from the mind's response to loss, whether this be a death or something symbolic, and theorized that a person's unconscious anger over their loss might lead to self-hatred and self-destructive behavior, which are depressive symptoms. He further hypothesized that the psychoanalysis of these subconscious thoughts could help resolve conflicts, which laid out the foundations for more systematic therapy. Whilst Freud's ideas were quite radical and widely dismissed by doctors who considered depression to be a brain disorder, behaviorist explanations for depression expanded on Freud's ideology and conveyed a new hypothesis: that depression was a learned behavior rather than a product of unconscious thoughts, and this implied that it could be forgotten. Effective pharmaceutical drugs to treat depression were unavailable in the first half of the 20th century. This remains true until we move further along our timeline to 1951, when Dr. Roland Kuhn discovered the profound effects that the drug imipramine had in reducing depressive symptoms, which arguably revolutionized somatogenic treatments for depression in establishing the foundations of potential for antidepressants. Dr. Kuhn's discovery of the first antidepressant followed the events of World War II, when a surplus of hydrazine missile fuel led to many chemists experimenting with hydrazine as a base compound for pharmaceuticals. This led to the development of medications such as isocarboxazid that initially attempted to treat tuberculosis in soldiers, but was found to have the effects of inducing mania in a small percentage of soldiers that were coincidentally also bipolar. This eventually led to the development and introduction of MAOIs as the first antidepressant, which was immensely significant in the amelioration of the neuroscience behind depression, which resulted from the initial research efforts being the mechanism to be associated with the modulation of monoaminergic neurotransmission at a synaptic level. MAOIs, as well as later iterations of antidepressants, achieve this by blocking the action of transporters or enzymes that target neurotransmitters. It can be noted that all of the antidepressants, with the exception of TCAs, were named based on the mechanism of blocking the transporter or enzyme that target neurotransmitter. For instance, MAOIs targeted the enzyme monoamine oxidase, responsible for breaking down and lowering the concentrations of neurotransmitters mentioned previously, and inhibited the function of this enzyme to increase their concentrations. Similarly, further iterations of antidepressants share this fundamental mechanism. TCAs inhibited norepinephrine and serotonin reuptake transporters. SSRIs block the transporters responsible for the reuptake of serotonin. NDRIs inhibited norepinephrine and dopamine reuptake transporters. And SNRIs also inhibited norepinephrine and serotonin reuptake transporters, but were far more selective in doing so. Despite being designed to interact with different synaptic transporters, there seems to be no statistical significance between the efficacies of each antidepressant class in treating depression, with over 50% improvements in depressive symptoms. However, the factor which divides the different classes in terms of how appealing they are is their side effects. In a study that spanned over 5 years with 238,963 patients, all aged between 20 and 64 in the UK, it was found that TCAs and MAOIs had significantly higher mortality rates, risks of upper gastrointestinal bleeding, and adverse drug reactions relative to healthy control groups and other drug classes, whilst SSRIs were associated with significantly higher risks of fractures and falls, with increased likelihoods of each adverse side effect with age. Despite this, there is considerable evidence that outlines the percentage likelihood for the most prevalent side effect to be approximately 0.6%, the highest risk associated with TCAs and the safest antidepressants being SNRIs. In comparison, ECT has a significantly higher likelihood of memory loss, which becomes immediately noticeable within a week of treatment, and it also requires the patient to undergo temporary paralysis and anesthesia, which makes it a much less convenient treatment. Diverting attention towards the psychosocial aspect, modern therapies such as CBT and IPT focus on tools that may perpetuate depression with a therapeutic goal being to teach the patient to change or adapt to set thought patterns, which is hypothesized to change dysfunctional attitudes. Results for both therapies were higher than a placebo, with a study on CBT finding 70% of a sample to be free of depressive symptoms after 2 years, and 85% of a sample with the same outcome in a different study on IPT after 1 year. However, their efficacy was still reported to be lower than that of antidepressants. Despite acknowledging this lower efficacy, it would be unfair to dismiss it as an inferior treatment option, as it has various features such as being relatively easy to teach to clinicians and a unique ability to adapt to a patient for enhanced accuracy upon monitoring, which means that its efficacy is not a defined value and can have varying success. Additionally, it is significant to note that the individual efficacies of both treatments can be combined to result in significantly higher effectiveness, thus showcasing that biopsychosocial model of treatments for depression is unrivaled by any individual component of the model. Whilst the successes of this model for treatments is conspicuous, its presence only partially illustrates the nature of advancements in treating depression due to an absence of one crucial component: diagnosis. Progress in the treatment of depression would have been largely limited without improvements in clinicians' ability to diagnose it, and so a vital revolutionary catalyst was a standardized diagnostic classification system with coinciding definitions of psychological disorders, known as the DSM, first introduced in 1952, with several iterations due to multiple revisions all the way up to May 2013, which saw the publication of the DSM-5. Additionally, the diagnostic process itself extends to the deeper roots of various scales, which can be argued to have been the first attempts at quantifying depression. Most significant amongst all of these scales is perhaps the Hamilton Depression Rating Scale, or the HAM-D, widely regarded to have become a gold standard for assessing therapies, largely as a result of how it shifted the perception of depression as being a chronic illness to a short-term curable one, which significantly impacted the environments of the psychiatric facilities by reducing the number of patients who would receive regular ECT, and it helped catalyze the shift towards antidepressants being used as the main somatogenic treatment. Other scales that were in competition with the HAM-D or developed from the foundations created by the HAM-D included the BDI, the CSDV, and the GDS, the majority of which had similar times of administration, which was roughly half an hour, and similar points of interest in what they assessed. However, the GDS is likely the most versatile amongst the scales, being the only one that can be administered without training and on a larger diversity of depressed patients, such as those with comorbidities like dementia or Alzheimer's. Holistically observing my findings, a reasonable conclusion might illustrate that depression was widely misunderstood in the 20th century, in comparison to the vastly more comprehensive modern conceptualization. Additionally, research efforts allowed comparisons to be made with various treatments and their efficacies and adverse side effects to construct more efficient models of treatment. However, despite our knowledge, it's also evident that our application of it, particularly psychosocial components, requires improvement when we consider largely unsatisfactory doctor-patient relationships and applications of therapy. And focusing our efforts on these aspects, we will achieve increased efficacies and hence a reduction in symptoms which decrease productivity and increase mortality.